I don't know if you knew this part, but this is the advanced seminar. Because if you may remember, before I was a member, and I meant to look up exactly what it was, but Keith, you may remember,
I was able to hear you.
but Keith invited me as a guest, and then I gave a short talk, not, a few years ago, and so enjoyed your questions and getting to know you all, and then when Keith approached me about being a member, I was delighted to accept. So I really, really loved that part, and when I was invited to come back, I thought, okay, now that you've all had the basic course, I'm going to engage you in a little more strenuous workout today in thinking not just about Silver Hill's place in our community, which I am so proud of and so delighted to be in support of, but about some of the larger problems that we're facing in this country around mental health, and particularly, and obviously from my perspective, the way in which I believe that as a system, as a healthcare system, we are failing, and in some very tragic ways, to provide adequate mental health care, particularly for those with more complex and severe illnesses. So today's talk will be a little bit of a combination of an overview of some of the things we do at Silver Hill, but really pairing that up with what we see as the larger challenges, not just here in New Canaan or in Connecticut even, but in the country or to some extent even in the world. So I apologize in advance if there are not uplifting parts to this, because we do have a big challenge ahead of us, and I think it's safe to say every one of us knows of some tragic examples of folks who didn't get adequate mental health care and for whom there can be really quite terrible consequences. And my mission, the mission of Silver Hill, is really to see if we can change that trajectory and start to improve the health care that everybody gets. But let me start with a little bit of history, because I can't resist. Now, I have to be a little careful when I give history, because there are people in the room like you who know more about the history of the region than I do, but I did want to share but I do want to share a great picture. This is Cruikshank House, which was, that building there was on the site of Valley Road. When you drive by, it obviously looks a little different than the big manor house up on the hill today, which we call Main House, but that was the origin of it. And when Silver Hill was purchased by our founders, John Millett and Elvira Parsons in 1931, that was the structure that they started with. And you can see it looks a little different today, but we are proud to have started there. But the picture on the other side, on the right, is an interesting one. This was not actually taken here in New Canaan. This picture was taken in Stockbridge, Massachusetts. And some of you who know my history know that I have a personal connection, because my job before being at Silver Hill and the CEO was being the CEO of another hospital called the Austin Riggs Center, which started in Stockbridge, Massachusetts. And the origin story for Silver Hill really goes back to Stockbridge. This man in the middle, his name is Austin Fox Riggs, and he was an internist. He was a medical doctor in the days really before there was such a field as psychiatry, the early part of the 20th century. But he was an internist who contracted tuberculosis. And in those days, before antibiotics, there were no treatments. So he was fortunate enough, both because of his own family connections, but also, even more so, his wife's family had an estate up in the Berkshires. And the treatment for tuberculosis was to take the mountain air. And so he moved there, but he did very well medically, and decided that he wanted to create a new kind of institution. And that was where what was at the time called the Stockbridge Institute for Psychoneuroses was founded. But it's also the origin story for Silver Hill, because there were two younger men in this picture. Immediately to his left, a man named William Terhune, and right behind him, a man named John Millett, who were also both internal medicine doctors who went to Stockbridge to train with Austin Riggs, and then later decided to go off on their own and start a new hospital, and that hospital is Silver Hill. So Riggs started in 1919. 12 years later, those two men moved down here. John Millett actually bought the property, but then he quite retired, but he moved to New York City a couple of years later. And William Terhune, pictured here, became the first long-standing medical director at Silver Hill. He was there all the way into the mid-1960s. And so much of the campus you see today, everything besides that, original house, was either purchased or built by William Terhune. And there are still folks who recall him because he was a major figure in town, a major figure in American psychiatry, and he lived in one of the houses we now use for our patients. We call it River House because it's right, if you're going up Valley Road and the main Silver Hill house is going to be on your left, it's that first house on the right past the cemetery, and the river is right on the other side of it. So he lived in that house with his family. And I actually met his grandson who came to visit, and he remembers playing as a boy in that house, and he recognized some of his grandfather's old furniture is still in some of our buildings. So if you hear people complaining the furniture is old, some of them are right. Anyway, so that is the origin. A group of back then, mostly men, but over time, obviously women as well, who really cared deeply about a new model for providing care for people with mental illness and addiction. But I'm going to flash forward now, and because this is too much of a current story to only dwell on the past. And I want to share something that, to those of us who work in the field, has become very, very obvious. But I think, unfortunately, we haven't done as good a job as necessary to communicate to the wider world, and I think it causes a lot of confusion. So when we read an article in the newspaper or we talk to our colleagues and friends, we talk about psychiatric illnesses as if they fall into neat categories. Someone says, oh, he or she has depression, or he or she has anxiety, or she or he has post-traumatic stress disorder or alcoholism, right? And the model that understandably we're using is taken from the rest of medicine, right? Someone has an appendicitis, or somebody has pneumonia, or somebody has a problem with their heart valve, right? These are separate, discrete illnesses, each one of which has its own cause, and each one of which has its own treatment, right? Very, very natural model. It turns out, though, in psychiatry, because the brain is such a more complicated organ, because the problems are so much more elaborate, that the only time it makes sense to speak about these as separate illnesses is when you have what I would refer to as mild illness. That is, people who are mostly doing well, they're going to school, they're functioning, they're going to work, and they have some degree of mild, maybe even mild to moderate symptoms. Obviously important that they get treatment, and important that we recognize, diagnose, and refer those individuals. But as soon as the illness gets more severe, it also gets more complex, and the diagnostic categories start to fail us. So this diagram, which was only published within the last 10 years, shows that if you take a number of different disorders, major depression, post-traumatic stress disorder, alcohol use disorder, generalized anxiety, the overlap between them ends up being larger than the pure versions, particularly when we're talking about more severe versions. So by the time you get referred to Silver Hill, or by the time we in our community hear about someone who's really struggling to the point that they can't go to school, or they can't work, or their relationships, marriages, and so on are failing, right? Those separate categories are no longer meaningful. That you have to understand these disorders not as these separate entities, but as a single, more complex scenario. And you'll sometimes hear people say, you might no doubt have, well, I don't know what he has because they've given him 4 or 5 different diagnoses. I don't know what she needs. She's had 4 or 5 different medicines. What you're hearing about is the struggle that we as a field have with the complexity of the illness. That is, we need to speak about it, we need to consider it, we need to diagnose it and treat it as one larger, more complex illness, rather than trying to break it down into these simpler categories, which, while appealing, no longer fit. The vast majority of our patients at Silver Hill fit into 3, 4, sometimes 6 or 7 different of the old categories. But we don't see them as having one separate set of problems. We see them as a single human being with a single mind, a single brain, who needs a treatment that recognizes how all of that fits together. And I believe that actually if you go way back to Lynn Terhune and to Austin Riggs and to John Millett, they saw this idea earlier on, and they built a system that was capable of doing that. Because if you specialize and you say, no, I only do this one thing, I only treat depression, or I only treat alcohol use disorder, or I only treat post-traumatic stress, that has a place in milder illness. But those systems and those treatments fail if you're not seeing the larger problem as a whole. Now, it used to be, some of us would talk about this as an idea, but to be honest, it didn't gather a lot of traction. And one of the reasons it didn't gather a lot of traction is because in the other fields of medicine, where there are some examples of this overlap in illness, you've got lab tests, you've got x-rays, you've got pathology, and psychiatry has lagged behind in an important way, again, because of the complexity of the mind and brain. And that, fortunately, is starting to change. So one of the areas of interest I had before I got into my current role was in using magnetic resonance imaging, or MRI, to look at the patterns in the brain, both structurally, literally how thick certain regions of the brain are, but also functionally, meaning which parts of the brain fire or work together. My interest was to use those techniques to try to understand this more complex set of illnesses. And it turns out that there's a lot of promise in that direction. We're not there yet. We are not yet at the point that you go to see your psychiatrist or even come to Silver Hill and get an MRI and then we give you a report. I hope we are going to get there soon, and within the next 10 to 20 years, I do think we'll be there. But this is, for example, a study that was done down in New York at Cornell Medical School, where we may think that there is one thing called depression. This investigator showed there are 8 different versions of depression, depending on the brain circuits that are involved. And that's a conservative estimate. That's just a first stab at it. So imagine if there are 8 different versions of what classically are called depression. And now you add in the other things I said, that depression never occurs alone in more moderate to severe cases. It comes with all these other things. Now we're talking about very individualized patterns of brain dysfunction that require a great amount of expertise to treat. And frankly, I think we're more heading in the direction, for example, of complex oncology or cancer diagnoses, where, yes, we still talk about where does the primary tumor come from, we still understand something about that nature, but as we know, the complexity comes into where has it spread, what kind of tumor is it, where is it affecting now, and how do we appropriately use all the tools to face it. That, I believe, is where we are going in the field of psychiatry.
Andrew, can I ask a question?
Of course, please.
You know, in the cancer field, what's happening too is they're finding that cancer morphs. Right? It starts out as type A and it becomes B and C. Are you predicting the same kind of evolution on the mental health side, that it starts out as depression, but then it turns into...
It's a perfect analogy, actually. I love that analogy, because we see this all the time. We often catch it late, meaning we've already now got the 4 or 5 different things. Right. But what we realize is there was a developmental trajectory. Something came first, some piece of it came first, but led to something else, right? And it can happen in multiple different directions, just the way it can in cancer. Imagine the individual, for example, who has a predisposition to a mood problem, let's say depression, but who ends up self-medicating with alcohol. And then alcohol leads to problems in their relationships and may even lead to medical problems. You see them when after all these things have accumulated. But you could also imagine somebody for whom it started with alcohol and led to depression and led to trauma and led to something else. So I think you're exactly right, that this sort of developmental trajectory of the cancer versus the psychiatric illness, we're only first starting to understand. But now, there's a really sad piece to all this. Just as we're understanding all the complexity in psychiatric illness, and one of the things that I'm very proud that we as a hospital do well, our country as a whole, I would argue, has moved in the opposite direction. That we moved away from institutions that were able to handle these more severe and complex illnesses to an attempt to treat things in a much more narrow or isolated way. Now, one could argue that the intention was good. The intention was, for example, to close older institutions that were sometimes known to not be great places. The old state psychiatric hospitals that you may drive by on highways and see places that look very scary and think, isn't that horrible that somebody would be there for months or even years without adequate treatment in the days before, for example, we had medication and other therapies. At the same time, though, those institutions provided a setting where those with severe and complex illnesses could get a level of care, both supportive care, community, and as the treatments evolved, the right treatment in a setting that was specialized for those complex illnesses. What we did as a society, though, was we maxed out in the 1950s. At one point, we had close to 600,000 psychiatric hospital beds in this country. Now, that was, again, a time before we had a lot of our contemporary treatments, but we might also realize that the population of the country was a lot smaller back then. This is now just speaking about Massachusetts because we have good data for that. We peaked at the point of over 23,000 beds just in Massachusetts alone, or about 1 bed for every 11 complex patients. But in the 1960s, 1970s, and really up until the early 80s, there was a concerted effort to close those institutions, what was called deinstitutionalization. It was led by an effort from the federal government to say, let's pull that treatment back into the community. However, those efforts were never fully funded. So what we did is we basically told the states, because these were mostly state-funded institutions, it's okay to close those beds and use the money for something else. And the federal government never came through on the money to fund similar services either in hospitals or elsewhere. So by the 1980s, now we're down in Massachusetts as a whole to under 1,000 psychiatric beds, or closer to 1 bed for every 300 complex patients. So you can imagine that when you hear about folks saying, I don't know where to go, or there's no place, or I'm sitting, my adolescent is sitting in the emergency room for days, this is a direct reason why. We're going to talk more about why we are stuck in that place right now, but I think it's important to understand how drastic that change was. Yes?
I'm also thinking about some volunteer work my husband did in violence prevention in prisons. So
Correct.
To the extent that you had people that had severe problems, I mean, to what degree is our prison system absorbing people that should have been
That's right.
staying in an institution?
No, you're exactly right, and there's a lot written on just that topic, and I'll just share a couple of thoughts about it. One is that even if you ask the question, what are the largest psychiatric institutions now, meaning what are the 3 largest psychiatric hospitals in the country that explicitly treat mental illness? They are, from first to third, the Cook County Jail, the LA County Jail, and Rikers Island. Those are the 3 largest psychiatric hospitals by declaration. But then, if you talk to people who work in the prison system, not even the psychiatric wings, and what you learn is that a very significant percentage of the population now meets criteria for psychiatric illness, and frankly isn't getting treatment for it in the prison setting. So I have colleagues who will volunteer their time or work in the prison settings to try to address this in some way. But we in a way, as a country, what we've done is we've taken these individuals who once had, I'm not saying perfect, but places to live and be parts of community, and either driven them to be homeless, and that's certainly many of our homeless are also suffering from psychiatric illness, or in prison. And the ones who are lucky enough to have the resources to be in neither of those, some of them come to Silver Hill, and we feel blessed for that, but some of them are also being managed by family members and being managed by our society in ways that are so far from perfect. Nobody I know wants us to go back exactly to where we were. We don't want to rebuild those institutions. But I think we have to recognize that something is failing in our current system. States are not paying for it, the federal government is not paying for it, commercial insurance is not paying for it. So we as a society end up paying for it in all these other ways, through the prisons, through, I believe, examples of crime and housing and educational systems. You talk to almost any other social service system and they will say, this is complicating their work and costing them money. So, unfortunately, there's a little more bad news, but this is bad news you probably already know. You can't open a newspaper or turn on a TV show and not hear about a mental health crisis. These days, it's very reasonable to think, well, that was made worse by COVID, or that was made worse by social media and phones. And the truth is, there's good data to support both those things. That is, both COVID and social media and phones seem to be worsening the mental health of people in this country, particularly our young people. But what's less commonly said is, the trend was already there, before phones and social media, before COVID. So we're exacerbating an underlying problem, a system that already was failing to provide for people with what I would call moderate to severe mental illness, and now adding even more stressors. So this is data about suicide rate that goes back to 1999 up to 2014. First cell phones, or at least the kinds of phones that our kids are using, didn't come until the middle of that. But already we were seeing the trend of suicide rates as rising. If you ask people about suicidal thoughts, those rates are even higher. Again, the trend goes back, in this case, we're chatting from 2008, long before COVID exacerbated.
Can I ask you about the trend?
Yeah.
So is it definitely a trend, or is it less stigma about the event?
It's a very fair question. And I think anytime you ask the question about the number of diagnoses, it's a combination, right? People have tried very hard to disentangle the two, and the best they can come up with is there is better reporting from a diagnostic perspective, and there is also an underlying increase.
Okay.
When it comes to suicide, though, I think those numbers are more clear. That is, we're not even counting in these suicide rates a lot of the overdoses that we might speculate may or may not be suicide. These are pretty clear suicides, and that rate is definitely going up. So I think, in a way, it's good that the stigma is dropping and people are talking more about this. We don't want to penalize anybody for counting better, but we also don't want to miss the fact that there are real increases as well. The one place that I would say it's more imbalanced is around a diagnosis, for example, like autism. That's a case where we have almost fundamentally changed what the word means over the last 20 to 30 years. And again, I'm not saying that's a bad thing, but it's confusing, because when people say that the rates of autism have gone from 1 in 1,000 to 1 in, the last number I just saw was 1 in 30, that is mostly about identification and not about an actual enormous 30-fold increase in frequency. But these are a little bit more shared. This, by the way, is data that is more self-report, but you can't talk to a young person or an adolescent without hearing about the increased rates of distress. Again, before COVID, and even before some of the social media. So we have to ask a bigger question. We have to ask the question is, what are we doing as a system? How are we failing people in terms of their mental health? So I promised that I wouldn't just leave you hanging with the terrible news. And I wanted to tell you a little bit about what we believe to be at the core of this and how we're going about fighting that at a place like Silver Hill, both here in New Canaan, but also more nationally. So this is the model. I do think that stigma and blame around mental illness continue to be one of the fundamental origins of the problem. If we can't talk about something, if we're ashamed about it, if we're blaming other people for it all the time, or particularly blaming the person who's suffering, of course that's going to go in a bad direction. But what's actually happened? I believe two major things. One is, and I'll talk about the first one in a second, I think we have gotten to a point where that stigma has been hijacked by the payers, and that sometimes is government, that sometimes is commercial for-profit insurance companies, as a way to save money. And I understand government has to balance their books. The commercial insurance companies have to be able to go back to their shareholders and show that there's a profit. But one way to do that is to avoid funding the things that people don't want to fight for. Fund orthopedic surgery, fund oncology, fund cardiology, all things that deserve to be funded, by the way. But you can get away with not funding psychiatric illness, particularly severe psychiatric illness, at the same level and letting it be somebody else's problem. But the other thing that's happened, and it's a complex combination, is it's also fueled what I would call a kind of regulatory zeal. And that is a misuse, I would argue, of government to impose more and more constraints on those who are trying to do appropriate treatment. That's basically driving people who do this kind of treatment out of business. So if you, at a fundamental level, ask any hospital system, ask the Yales of the world, the Hartford Healthcares of the world, the Nuvance or now Northwells of the world, say, why don't you have more psychiatric beds? You know, how could you possibly think we have enough when your emergency rooms are filled with people waiting for beds? If they're being honest, they will tell you two things. One is, we can't afford it because it will lose us money, and we use that same space for another medical or surgical service, and we can at least break even, maybe even have a profit that will then help subsidize other areas. I'm not claiming any of these systems are making a lot of money, but at least they have to break even. And every time they have a psychiatric patient, they lose money because of the way the healthcare system is structured. But the second thing they'll say is the regulatory burden is overwhelming. That the amount of work we have to do in order to just meet the bare criteria for a license to provide these services and then maintain that license is inordinate. So I'll give you an example, and any of you who looked at your medical record may have some sense of this, but I'm going to give you the psychiatric example. A typical psychiatric stay in a hospital for an acute purpose is about 7 days. Not sufficient, that's driven by the insurance industry, but let's just take that for what it is right now. That generates about 72 pages of notes. And if you read those notes as a professional, what you realize is the informational content probably could be summarized in about half a page. Meaning, all that other verbiage, all that other boilerplate, template, CYA, all the ways in which people use documentation to meet the regulatory standard actually hurts the quality of care and costs a lot of money, right? So on average, the estimate in the field is that about $1.7 billion a year is wasted on essentially meeting regulatory demands that are not in the service of our patients. And does that mean psychiatric hospitals shouldn't be regulated? Of course not. Every industry should be regulated in an appropriate way. But if we focus on this regulatory side, we're furthering the problem of driving folks out of business. And just to add one last piece around these rates, I mean, I've sort of referred more generally to the lack of good funding. The common standard in the field is to use Medicare as a standard. Medicare is not a great payer for any services, but it has a sort of rationality to it. It's sort of based on what it costs. But that doesn't mean that's what insurers pay. In fact, you can measure, as compared to Medicare, how much are various services covering. So if you look at in-network reimbursement compared to Medicare for non-psychiatric illness, you see somewhere between 10 and 20% higher rates than what the Medicare baseline is. But if you look at mental health or substance use disorders, you see somewhere between 5 to 10% below Medicare rates. So a significant shift, and this is what's called a lack of parity. You may have heard this term, mental health parity, which says, why should we be setting a different set of standards or a different set of reimbursement criteria for mental health or addiction as compared to physical health? And in fact, since 2008, it's been the law, the federal law, to say that no insurance company is allowed to discriminate against mental illness in terms of its standards, yet it's an unenforced law. The law was written without an enforcement criteria. There have been some attempts over the years, both at the federal and at the state level, to improve that, but we're still suffering from a lack of enforcement of parity. So we've got a lot of work cut out for us. And this is where, you know, I get to sort of say how blessed we are. I imagine we have to stop in just a minute. Is that right, Tom? So give me 2 more minutes, and then I'll stop. We are blessed to be in an area where we are able to essentially run much of our business at a loss and subsidize it by other parts of our business. So as many of you are aware, there is a private pay aspect of Silver Hill where folks with the resources to pay cannot use their insurance and pay. But what we do with that is, as a nonprofit, is we subsidize all those areas of mental health care where the insurance simply doesn't pay enough. So all of our inpatients at Silver Hill, that is the folks who come onto a more secure unit because of an acute illness, use their insurance. All of our outpatients at Silver Hill, that is those who live at home and come during the day, use their insurance. Our assessment service that we run in town is not paid for by patients themselves. But we subsidize that in part with some donations, but in large part because of parts of the campus where people are willing to pay. And we're very proud of that. So here are 42 beds that are pretty much always filled between our main house and our acute care unit. But here's our residential adolescent unit with 10 beds. Here's our substance use house, which we sometimes call Scavetta House, which has 16 beds. Here's our another residential, this is River House. This is actually where the medical director used to live, 10 beds. A house that helps young people with psychosis, we call the Lodge. Our trauma program, and most recently our executives and professional program. All of these programs subsidize the programs that take insurance and that are free. Most recently, we did open up a new program in New York. Currently is a private pay program, but with the plan to be able to subsidize care there as well. So it's the only way we have to do this. Hospitals that don't have that ability to cross-subsidize essentially can't do it. They got a lower quality. We would like to broaden this model to other locations, New York being sort of the first one, but we hope that others will take this on. And we plan to use this and have started using it to lobby for better reimbursement and for better care, not just here in Hartford, but where I just got back from, Washington, D.C., where there are people who care about this. It is a bipartisan issue. It is not an issue that divides neatly along party lines, but we need to help make people aware, and then we need to do things to continue to improve our services. So I will stop there. Thank you.
We will have you back.
Okay. I did.